Hello, everybody. I'm Dr. Larry Edwards. I'm the chair and CEO of the Gout Education Society. The Gout Society is a nonprofit organization directed at educating the public, patients, as well as physicians about the disease gout. Um, Tonight, the Gout Society is going to sponsor a webinar entitled A Multidisciplinary Approach to Managing Gout. Promoting consensus in treatment. Joining me tonight is a panel of 5 people that are well-versed in the management of gout. They are gout experts in their own right. And we'll be discussing various aspects of gout treatment with these individuals. Let me go through the group right now. Ted Mikuls is a rheumatologist as well as the vice chair for education for research and a professor in the Department of Medicine at the University of Nebraska. Mark Segal is a nephrologist. He's senior associate dean and professor in the Division of Nephrology, Hypertension, and Renal Transplant at the University of Florida. Paul Doghramji is a senior family physician at the Collegeville Family Practice and the medical director at Ursinus College in Collegeville, Pennsylvania. Nicholas Romansky is a podiatric medical specialist as well as a podiatric surgeon in Media, Pennsylvania, and a contributing editor to Podiatry Today magazine. Joan McTigue is a PA and has been in the rheumatology section of the Malcolm Randall VA Medical Center for several decades, and for about 10 to 15 years ran the gout clinic in that institution in Gainesville, Florida. All are recognized, again, as experts in the field. Just in way of introduction about gout, it is the most common inflammatory arthritis. It affects about 4% of the adult population, or close to 10 million people in the United States. It's a chronic metabolic and genetic disease, something that's underappreciated, and is also one of the most poorly treated chronic diseases that there is. It's a disease that's surrounded by mythology, and many of these myths really do interfere with the good treatment of gout. People believe that this is a disease of overindulgence primarily, and that kind of embarrassment sends people hiding when they develop this, and rather than getting appropriate therapies. There's also concerns about different medications by people that are ill-informed, worrisome things about what can happen with these medications. The Gout Society is primarily directed at trying to dispel a lot of these myths. We're going to be talking about gout in its various stages and how the various specialists that we have on the panel first encounter gout. But gout, you should all know, is a disease of uric acid excess. In males, that begins if they are genetically predisposed to elevated uric acid levels in the body in their teenage years. And over the next decades, if they are significantly hyperuricemic or elevated uric acid levels, to develop deposits of uric acid crystals around the body. At some stage, usually for males in their 40s or 50s, will develop the onset of an acute inflammatory disease. If left untreated, this will progress over years and decades to a chronic arthritis and also a destructive arthritis. In women, it's a little slower disease process because they're protected by estrogens up until menopause. But following that, they have a course that's very similar to males. And so this isn't a male-exclusive disease, as many people think. Women are frequently involved in postmenopausal times just as frequently involved as males. It's a chronic disease, so that it accumulates over time. In fact, about 20% of the male population over the age of 75 has gout, and about 5% of women in that age group likewise have gout. We're going to run past a number of topics about this, but the first one is really how the different specialists end up seeing gout. That we know, again, the gout progresses from these stages of predominantly a flare to the stage of being a chronic disease, and then one of more destructive disease. And the literature would tell us that the people on the panel see patients at different stages. The primary care physicians, predominantly family practitioners, see them early on with symptoms of gout, flares in their practice, and relatively few later on in the more chronic stages, whereas rheumatologists predominantly see people with more chronic disease symptoms rather than the intermittent phase. And the whole process of coming together as a multidisciplinary team is so that we're not like the parable, the Buddhist parable of the blind men describing an elephant, to just looking at them from different stages and being very parochial about our approach. So what we're going to describe now is just go around the panel and talk about the signs and stages of gout where the various panel members might initially see these patients. Joan, why don't you start off as a PA in a VA system that's a very focused type of referral process, but running the gout clinic, when would you first see patients with gout?
Well, the nice thing about the VA is that it's a relatively integrated system. So people don't just sort of show up on your doorstep. People are referred in, and they're referred in largely from the emergency room or the primary care environment. And I think that the primary care environment and the ER is are such overwhelmed environments that they very often will, once they knew there was actually a gout clinic, they were very happy to push off the gout, a piece of the person's illness, to us. And I think it's quite different, in other settings where there isn't a gout specialty clinic. That was one of the very nice things of having it. We could take people in from all directions and quickly and kind of get them settled, rather in a short period of time. So it's one of the nice things about having a dedicated clinic.
Okay. Thank you. Ed, what stage do you see gout patients at?
Well, I mean, the short answer, Larry, is really all stages. But I think as a rheumatologist and at an academic medical center, I tend to see patients, as you described, who are maybe further along on that spectrum. And I think I particularly see patients as they've begun to get frustrated with the condition and frustrated with care and, not getting the answers they want. And I think that's, they often find me one way or another in that kind of frustrating process. I also get a lot of referrals, not surprisingly, I think in an academic medical center, from other specialists in patients who have complicated gout, and where the specialists foresee potential problems with some of the medicines we use in gout management or some of the medicines they use to treat the comorbid illnesses, and really want a collaborative approach to these patients as they take care of the many problems they have. And so that may be chronic kidney disease, it may be heart disease, heart failure, you name it, high blood pressure, et cetera. And I'm at a big transplant center, I think, as you are, and there's a big transplant population. Treating gout, which is more common in the transplant patients, can get complicated awfully quickly. So variety of patients, but typically, maybe further along the spectrum than what folks in primary care necessarily see. But I think my other specialist colleagues on the call probably see similar patient populations.
You want to jump in there, Paul, as a primary care family practice?
Yeah, in primary care, we're the main ones that see gout initially. And I'm going to include, urgent care as well as, family practice, internal medicine. We see patients coming in all the time with joint pain. But we will start to think about gout in usually a male in their 30s, 40s, or 50s presenting with joint pain, typically in the foot, usually the MTP joint. But we also have to keep an open mind to the possibility of it being in the ankle or knee or even in the wrist. So in primary care, we have to be on the lookout for this. And what we teach primary care providers all the time is, look, when you have a severely painful joint that acutely develops with minimal to no trauma, that's what you want to think about. It's very important that as we teach other primary care providers, whether they're students or in seminars, that when patients come in with a joint pain that's relatively atraumatic, that's relatively severe, acute onset, that typically happens in the farthest joints, like in the foot, like the MTP joint, the ankle, or maybe even the knee or wrist. You want to think about the possibility of gout, especially in those that have certain comorbidities, especially obesity, diabetes, hypertension. These are some of the comorbidities we think about. And there's a specific way that we clinically identify this, and then we do some blood tests to corroborate what's going on. Very common in primary care, but not, as you said very earlier on, Larry, not very well managed in primary care. We need to do a better job at identifying, but as well appropriately treating the acute event, but as well as prevention. We need to tell our primary care colleagues about that. It's very important to know that this is very common, and it's important to know how to diagnose it early and manage the acute condition, but then very importantly, prevent the onset of many of these acute conditions.
Agree with all of that, Paul. Yeah, Mark, as a nephrologist, how do these patients come across your radar screen?
So I see two general categories. One category is a patient who tells me, yeah, he had a gout attack and he's not on appropriate treatment. And, they were symptomatically treated and no continuous treatment. So we start educating the patient then and starting the appropriate treatment. And the other group of patients are those who come to me and might complain of a non-traumatic monoarticular joint pain, and I'm checking a uric acid because as CKD progresses, the uric acid can increase. And so in those patients, we're actively trying to look for it.
Sure. Yeah, and that's important. So many of the metabolic diseases that gout's associated with, including metabolic syndrome itself, come across subspecialists, the diabetologists, the hypertension and kidney disease like you, hyperlipidemias. All of those are part of the near neighbor effect, I guess, of metabolic diseases and gout. Yeah. Nick, tell me about podiatry. How do you see gout patients? Is it the acute problem of fitting in a chair or fitting in a shoe, or is it that their feet have been deformed over years? And
yeah, okay. So I think it comes from a multiple approach from listening to all the specialists before me. So the podiatrist, many times, just like the family practice is, and the primary physician are the first people to see this, whether acute or chronic. What we are seeing now in all ages, even the 20-year-olds to the 70, 80-year-olds, believe it or not, from a sports medicine point of view, a recreational point of view, these individuals now are in retirement villages. They're all playing pickleball. They're all playing sports. They're all being more active, but they're also more socially active. So they're playing. They're not hydrating. They're playing longer than they should. They're usually having some form of alcohol or drink thereafter, eating different foods that they're not used to when they used to be at home. So we're seeing that now, not just with other injuries, but we're also seeing it with just everyday life of being more active at any age. We've seen it at the college level because pickleball is becoming very hot in the college level. It's hopeful that one day it will be an NC2A sport, or they're even thinking about the Olympics. But more likely, it doesn't discriminate with any age, and we're seeing it in the 20-year-olds to the 80-year-olds from a recreational point of view. That said, being part of the medical team and the first people see it, yes, we do see it post-kidney transplant. Yes, we see it in the big toe joint, and also asking them where else will it may hurt, like a wrist, like Paul said. So I think you have to listen to the patient, be really cognizant of that. We're really thinking about that this may be gout. It may not just be in one joint, the big toe joint, which is 70% of the function of a big toe is the foot. Okay, same just like the thumb is 70% of the function of a hand is the thumb. So I think you also got to look at this not from a systemic point of view, but it may just be a sesamoid issue at the big toe joint from playing sports or pushing off or actively walking, that people are into walking and running now, but also may just be DJD, or what we call hallux limitus, which is painful, limited motion of the big toe joint. So we really, as a podiatrist, the foot is connected to the rest of the body. And that's my theme for this meeting tonight, is the foot's connected to the rest of the body, that we as podiatrists, foot and ankle specialists, whether you're an orthopedist, foot and ankle specialist, or anybody that deals with a foot and ankle, that really it is connected to the rest of the body. And we have to ask the appropriate questions, get the appropriate blood work, and be part of the team to collaborate through EMR.
Yeah, good. Yeah, I think a common thread through all the comments was awareness of the disease, and that there is a differential. Part of the activities of the Gout Education Society is to do surveys of patients with gout every so often, just to see how deep the misconceptions about the disease are. And some recent ones, I'll just talk to you about that. About 1 in 5 patients with gout don't view it as a serious disease at their process, at their stage of it, that they're not aware that it can progress on into a crippling and deforming form of arthritis. That few understand the risk factors that are associated with gout, that nearly 70% don't associate gout with either kidney disease or diabetes or hypertension or chronic kidney disease. All of these metabolic problems, that only 1 in 3 patients with gout take a medication on a daily basis, but only 1 in 10 is actually going to stay on that medication long enough for there to be a substantial change in their metabolic problems. So it's a undertreated and underrecognized and underappreciated disease, both by the general public, the physicians that take care of the patients, and the patients themselves at various stages. Let's move on to some other questions. Is there an appropriate time for referral from primary care to a specialist like rheumatologist? Paul, what do you think about that?
There are several instances where a primary care provider will want to refer a patient with a painful joint that's acutely occurring in primary care. In one instance, they may want to refer immediately to get an arthrocentesis done, or just taking out some of the fluid for analysis. That may be one. They may call in a rheumatologist, orthopedist. That's not that commonly done. A lot of primary care providers will actually do an aspiration, a joint aspiration. But the more common reason why a primary care provider will want to refer most commonly to a rheumatologist is either the diagnosis is in doubt, or the primary care provider is having some difficulty with managing either the acute events or maybe even in getting the patient's uric acid to target, which we all know is less than 6 milligrams per deciliter. And in other instances, the reason for the referral might be that the patient wants to see a rheumatologist for corroboration. So these are some of the instances why a primary care provider will refer.
Yeah, that's right. Progression of disease to a more chronic state. Ted, when do you see people referred to you for just because they can't well be handled with allopurinol or febuxostat, the two most commonly used urate lowering therapies?
I certainly see that, and I agree with Paul on really what the thresholds are. And they vary a lot. It's probably not surprising that providers are very different. We're all different on this phone, but I think the threshold that different providers have is different. There seems to often be a wall, so to speak, with dosing of allopurinol, the most commonly used drug that we use to treat gout and to lower uric acid. And so allopurinol is interestingly made in 100 and a 300 milligram pill, and that 300 milligram dose often seems to be this wall that people aren't willing to climb over. And the average dose we use in trials is often 400 to 500 milligrams is the average dose that's needed to achieve and maintain uric acids. And so we will often take over patients at that what people call conventional dosing or standard dosing, and move those doses up and monitor those patients appropriately. I think there's also not as much comfort with other urate lowering drugs, and certainly if a patient has taken larger doses of allopurinol or other drugs without reaching that goal, then we often see those patients. And what other therapeutic approaches or more advanced approaches can be used in these tough to treat patients?
And there are therapies for people with very advanced disease now. Pegloticase is a drug that actually breaks pre-existing crystals apart and is quite effective in that regard. Mark, jump in on this. Nephrologist, not in your division because they're all well trained, but there has been a kind of a false impression that allopurinol is somehow toxic to the kidneys and all, and so not going up above 200 or 300 milligrams is commonplace, and a lot of people that worry about that thing. What's your take on that?
Yeah, no, I agree. It's a big problem. And oftentimes I have people established on allopurinol who will get hospitalized and taken off of the allopurinol because they have CKD.
Yeah.
And so we're always fighting that. And I think the important thing is, in someone with CKD, is you start at a low dose. I'm very, very conservative. Start at a really low dose, 50 milligrams every other day, and increase it by 50 milligrams every other day, every 2 weeks. Now, I will say those with CKD, sometimes you don't need to go as high to achieve your target. So, maybe I'll go up to 200 and then check a uric acid level. And if I'm where I need to be, then I'll stop. If I'm not, then I increase it based on the uric acid level that you want to attain, which is less than 6.
With no real upper limit of where you can go to. The target is going to 6, and whatever dose of allopurinol it takes to get there is the right dose for that person.
Absolutely, yes.
Okay, yeah, that's a hard lesson to disseminate out there in the medical community and in the patient community as well. The one thing that I think also interferes with the treatment of gout is the stigma that surrounds the disease, that patients are embarrassed by having this disease, again, because of the kind of historic references of overindulgence, of this is a disease of excess, of self-inflicted type of problems. Joan, how do you talk to people about that particular thing when they come in the clinic?
Yes, it's hard. They're embarrassed, and they also are very quick to blame themselves. Mm-hmm. And they really don't know that the basic issue is hyperuricemia. So I spend a fair amount of time trying to explain to them that it wasn't that shrimp that you ate. That may have been what triggered the flare, but that's not what caused the gout. So make more folks understand that hyperuricemia is the basic issue at hand is difficult and has to be reinforced all the time.
Right. Yeah, it's I think the research in the field of genetics and gout over the last 8 to 10 years has been very eye-opening and helpful in dissuading people that they are the sole cause of their pain and suffering. That we now know that, and we've known for many decades that gout's a familial disease, that it certainly runs in the family, and that you're at different levels of risk, whether it's your brother that has gout or your father that has gout or your sister or your mother that have gout, all have different associations. But we now know that most hyperuricemia is caused by some genetic defect in the process of elimination of uric acid, predominantly from the kidneys, but also through the bowel with mutations of genes. So there's some solace, and I think that you can win people over to being more open about their disease and sharing the consequences with their family, because the family should be on the lookout with that and other metabolic problems. One other interesting statistic that we found out from just polling patients is that that very few of them knew that there is gout management guidelines out there, either from the U.S. or European or British. Lots of arthritis societies have their own set of gout guidelines. All of them center around the idea that you have to treat to target, that there's a level of uric acid in the blood that results in precipitation out, and this happens over years and decades before the first flare of gout ever occurs. But deposits of uric acid around the soft tissues, the joints, or even on the cartilage is the hallmark of that the gout guidelines recommends in the United States a target of less than 6 milligrams per deciliter. The British are a little more forceful and go for a target of less than 5. And a lot of us, I know, Joan, in your clinic, you were always shooting for less than 5, and you can achieve that in most all of your patients. On the other side of that, the American College of Physicians came out a while back, about 2018, with a kind of a different take, and promoted for a short while the idea of treat to avoid symptoms. I know you were thoughtful about this, Ted, and along with most people that were gout experts in the field, of opposing that sort of process. I should say, since that time, the ACP, the American College of Physicians, has backed way off and don't consider themselves having active guidelines right now. But what is your take on the treat to avoid symptoms?
Yeah, I mean, on a very thoughtful, forgiving day, I think that I understand the concept there. I do. And I think some of the pushback against treat to target probably came from other conditions where data really suggested that a treat to target approach in certain circumstances could be associated with poor outcomes. I don't think there's equivalent data in gout, and I'm aware of no data that a low uric acid, no really compelling data that a low uric acid portends the kind of risk that like a low blood sugar does in diabetes or a low blood pressure does. I mean, they're just not equivalent. So I think the comparison that was made and the concerns about treat to target were really not appropriate. I don't know what treat to avoid symptoms is. That's the other major problem with that approach. What does that mean? So does that mean I should put someone on high doses of steroids, and as long as they don't have gout symptoms, we're doing a great job? I don't think any of us would think that that's a good treatment approach.
Right.
And so, putting that in a treatment algorithm is just, to me, almost impossible. So I could go on, and I'll just abbreviate it.
Yeah. Well, I think the idea was treating flares as they come up, but not really worrying about the underlying metabolic process. Part of this problem is where a lot of patients end up with their acute flares is in the emergency department. Nick, and the outcome of that is that they frequently will get a shot of some opioid and be sent on their way. I don't think that there's really a place in the management of gout with opioids. When you see somebody with acute gout or a history of gout, is there some recommendation that you make to them about treating their symptoms?
Yeah, so I think the theme in the past here with all the specialists, we are always told to educate, but I really think it's a re-education process, or to re-educate, because they have Dr. Google, they have Dr. Amazon, they have their family, their friends, the haze that they have around them about gout, and it's more common than you think. And when they come into my setting, I'm the one to refer to the rheumatologist, the nephrologist, if they have not seen the nephrologist in a while, and they've had a kidney transplant or kidney disease. I'm the one to refer back to the primary or call the primary. But I have to diagnose and treat, and then get them comfortable so they can walk, whether it's at a midfoot area, a big toe, an ankle, a knee. For that matter, my job is to keep them walking and to keep them active at any age. So I'll put them in a surgical shoe, whether it's in the ER setting. I will get baseline blood work and start them on some form of medication until I can get them to the specialist or the primary doctor. The issues I have nowadays, and we have in medicine since COVID, really, is that getting the patient into a specialist or into that primary doctor, possibly even if they can just do some telemedicine to help the patient out and coordinate care with myself. So I got typically I'll put them in a surgical shoe. A lot of times I'll put them in a little special splint to put that big toe to rest, if that's what it is. Worst case scenario, I can put them in a cam walker boot, rarely, or cast, and then kind of just see how it is from there, how they can ambulate and get around, and talk to the family members as well, what we're dealing with as a differential diagnosis, and making sure it's not a fracture or anything else. It is a systemic issue.
Yeah. Mark, unlike allopurinol, where you're not terribly concerned about chronic kidney disease and treatment with that, I suspect that in treating acute gout, the non-steroidals probably are taboo in your mind, just the way that and endocrinologists don't want to hear about the use of oral steroids for the treatment of this. How do you approach people with chronic kidney disease and acute flares?
Luckily, I don't have to. It's very difficult because you don't want to use any of the non-steroidals, so you're left with over-the-counter Tylenol. Whether a lot of these individuals, as you said, have metabolic syndrome and diabetes, and so now the prednisone is complicated. So I think it's just a lot of risk versus benefit analysis and taking each patient as they come, and short-term still over-the-counter pain medication may be okay, depending on make sure they're well hydrated. If they're not on an ACE or ARB at the same time, and it's a short-term treatment, then you might be better off with a non-steroidal than other medications.
Yeah. Paul, how about you? You probably see a lot of gout patients with comorbidities that are precluding any of the top three usual treatments for gout flares: the colchicine, the non-steroidals, and the prednisone.
Again, let's just set the stage. The most common patient who comes in early on is going to get colchicine, the typical 2 tablets right away, then 1 in an hour. They'll pretty much do well, and they won't have many exclusions to prevent them from taking that medication. Others will do better with NSAIDs, and really any NSAID at high doses are going to be okay unless they have chronic kidney disease or other types of comorbidities that preclude NSAIDs. In others, a steroid like prednisone or methylprednisolone may not be a bad idea. You just got to make sure that you use it for a long enough period of time so I don't get a rebound effect. But let's also not forget about it, the fact that I will often also inject the joint with a corticosteroid. And sometimes that's the best choice in a patient that has many comorbidities where you can't use systemic medications. So with these 4 methods, you should be able to get somebody out of an acute attack.
Yeah. Joan, you're an expert at getting people out of attacks. Do you have any suggestions to this?
A great deal of patients are very fearful of colchicine, for example, which is a great drug to break a gout flare, because they were given the medication sort of in the older tradition where you just keep taking it every hour or 2 hours until the flare breaks or until you spend the night on the toilet. So, I always stress to patients that recent research, I use this term research, has shown us that you can get by with a much more modern approach to the use of colchicine. So I like to use a fair amount, because using it in the newer doses, people don't really get those kinds of dreadful side effects. There aren't too many people who really can't take it, who have too many contraindications. And sometimes you could just hold those other medications for a while if you are worried about a drug-drug interaction. So I'm a big colchicine fan.
Is there a role for IL-1 inhibitors and treatment flares?
Yeah, that's my favorite drug. Yeah. And particularly at the VA where the comorbidities are so complicated. Sometimes that's the very best thing to do, is to use an IL-1 inhibitor just to sort of get them through it. And then depending on what I think we need to do next, sometimes you can roll them over to even a tablet of colchicine a day until, you start to get them on a good urate level therapy regimen.
Yeah. Yeah, colchicine has had a rough history, but it's about a 3,000-year history, so it does have some staying power.
Yeah.
Along
all the old regimens.
Yeah, along that line, Ted, colchicine has gotten a new life to it, seeming to protect people with significant heart disease from having acute MIs and strokes. Has that changed the way you use colchicine or how long you use it for?
Yeah, it's definitely changed the way I think about it. I don't know that it's changed my practice too much yet, and I say that because I tend to prophylax people probably on the longer side even before that data came out with colchicine, because like Joan, I think it's a pretty well tolerated drug. So when you prophylax folks, I think you can, on most patients, like 0.5 to 0.6 milligrams a day, depending on what formulation's available, usually is pretty good and pretty safe, even with medicines that are known to have interactions. I think those are infrequent at that lower dose. So I think it's a pretty effective medication and pretty darn well tolerated. The data that you mentioned in terms of reducing cardiovascular events is really intriguing. And I think there's going to be, we don't know whether that translates to gout, but I'm also not clear why it wouldn't. And so I think it'll have benefit there, but it'll be important to see that. And I think it's led to a lot of other therapies that block the same proteins that we're going to see evolve in gout management over the years. So it really, really interesting therapy. I love the idea we can get 2 birds with 1 stone. So
the data that was published really was looking at the incidence of acute myocardial infarction, cardiovascular death, and strokes, depending on the time from the last gout flare. So, we tend to think of gout flares as being a very intense but short-lived inflammatory process that goes on for a week to 10 days, and then the joint returns to normal. We now know that the cytokine-driven inflammation is much more protracted than that the acute inflammation caused by IL-1 and IL-6 does last a relatively short time, but there's a feed-on inflammatory process that goes on for months and months afterwards, so that we end up with an inflammatory disease in gout that's chronic and shares that side effect profile of other chronic inflammation that goes on as far as its worsening of heart disease. But this data showed that that the incidence of acute MI and strokes was very high in the first 90 days following acute flare of gout. And that as you stretch it out to 90 to 120 and 120 to 180 days, it declines slowly over that period of time to a baseline. So now the thinking is that if we're prophylaxing with colchicine, that we just run it on out. The inflammation caused by gout is induced through the activation of this NALP3 inflammasome, which seems to be also an important inflammatory process in myocardium as well. So there's a bunch of overlap between heart disease inflammation and gout inflammation.
And I would just add, Larry, just so the audience knows that colchicine is now FDA approved as a secondary prevention in cardiovascular disease. So that's a newer development and really important for our patient population.
Paul, what problems do you have with just forming collaborations in your management of gout? Do your toes get stepped on if if the rheumatologist doesn't like the antihypertensive that you have the patients on, or do they run up? You're a very good and successful treater of gout, but just speaking for family medicine, does it tweak you if the rheumatologist sees them and runs an allopurinol dose up to 600 milligrams?
There are a lot of comorbidities associated with gout, as we've already talked about, and the specialist that I refer to, let's say the rheumatologist, is going to look at that and is going to want to make some adjustments with medication. One of the things that they do is, in fact, alleviate the fear that primary care providers have that you can go up to 800 milligrams of allopurinol. In fact, if I'm not mistaken, in Europe, the ceiling dose is 900 milligrams. So we can do that, albeit cautiously. And I think the rheumatologist can help us do that. Febuxostat is a little bit easier at 40 and 80 milligrams. And I believe, if I'm not mistaken, in Europe, it's all the way up to 120 milligrams. And I think in this country, it can be used off-label to that. So rheumatologists will do a lot of things that help us out and allay our fears about getting our patients' uric acid down to a target of 6 milligrams per deciliter. And by the way, in difficult cases, we try to get them down below 5 milligrams per deciliter. So yes, that can be a bit of a challenge, but rheumatologists, most of them are very good at allaying our fears and helping our patients get to their goal using the most traditional medications to lower uric acid. As far as comorbidities go, I think it should also be said that we in primary care also know that some medications we prescribe, like for hypertension, losartan does lower uric acid a little bit, and also atorvastatin for cholesterol can help lower uric acid a little bit. So we kind of have to know about all these things to help our patients get to target. It's a collaborative effort that we have with our rheumatology buddies, and also, by the way, our nephrology buddies will also get involved when chronic kidney disease is involved, and then they'll try to manipulate whether it's febuxostat or allopurinol to get our patients to where they should be in a safe way. It's all part of being the team to help our patients not only get their joints to where they should be, but also all their comorbidities well taken care of.
Yeah. Do you have anything to add to that, Mark, as a hypertension expert as well?
No, and I think, of course, when you're talking about medications, when you're starting diuretics, you can increase the uric acid. So you have to be careful about that. And that oftentimes can promote a gout attack. And the first diagnosis of gout can be made after starting a diuretic.
So if you have them on HCTZ or even a loop diuretic like Lasix, if you could, and they're being treated for hypertension and not heart failure, substituting in a drug like losartan can make up to a 2 milligram per deciliter improvement just with that switch.
No.
Rarely is it ample to bring the uric acid level down to a target. So we are going to be relying on pharmacologic urate lowering therapy, but these switch outs like that one, substituting losartan for HCTZ, is something that physicians should be thinking about. Yeah, that's good. Let's talk a minute about mythology of gout, of the misconceptions that you hear from your patients that can actually lead to interference with good management, or misconceptions that you hear from other health professionals about the disease. Let's start with you, Joan. You've always had good stories that you would come in and tell us about.
Yeah. My personal favorite was a fellow who came back for his second visit and nothing had changed, and he hadn't taken his medication, his urate lowering therapy, and had stopped his colchicine. And why? I don't like to take advice from women. So that was what I'm sure you guys haven't heard very often. But at that point, it was, okay, you're next door to see my buddy. But I did keep a little notebook once of all of the reasons that people gave, and they were, from the bizarre to the, really understandable. A lot of it is old advice that had been given to them years ago, like to stop taking their allopurinol when they have a gout flare. That had been drummed in very, very often to people. I don't even know the origins of that myth. Another one is you can do it with diet, which people get a lot from their friends. And I have to sort of explain why that's not the case. Also, sometimes pharmacists are not our best friends and put a little bit of fear into patients. So they kind of come away from our visit, and they're afraid of what we told them. And so they don't call us to double check. They just sort of like go on their merry way. My personal favorite story had to do with a guy who came in and told us that he had a pro-gout lifestyle, and what could we do to help him with his pro-gout lifestyle? He was a hunter. He ate red meat all the time. He drank beer all the time. He walked and wore these hunting boots, and everything about it. So, we told him we can get you there. We're just such we have to push hard. And he was willing to do that because he wanted to keep his pro-gout lifestyle. But we did get him to target.
Yeah, that's true. Stepping in and trying to interfere with lifestyles can be something that puts distance between you and the patient as well, and they'll stop listening to reason. Ted, what kind of things do you hear that drive you nuts?
We've talked about a lot of them. I mean, and I'm interested to hear Mark's take, but especially because I think kidney disease and the misconceptions around allopurinol in the context of kidney disease has probably been the thing that has been the biggest barrier to effective gout management out there for me. And I still get notices from pharmacists, like what Joan was probably alluding to, that, geez, do you really want to use that 300 milligrams in this patient with renal insufficiency? Yes, I do. So it's still getting those notes. I think the other is gout is an interesting condition. I think more than other conditions, although this is true for lots of different types of arthritis, patients really want to go. I think Nick called it Dr. Google. Dr. Google is a big provider in gout management, it seems like, and newest, greatest therapy, cherry juice extract, etc. and just not a lot of data and not a lot of probably true efficacy of a lot of those therapies. And so we have patients wasting a lot of resources, a lot of time, and a lot of energy on things that just aren't going to help their gout. So I think those, for me, those are probably the two biggest.
Yeah.
I think one of the things that COVID taught me was the value of telemedicine in these things. It allowed me to to follow patients more closely. So usually the clinics might not have time for us to see somebody back in 2-3 weeks, or we could get a quick telemedicine call in. And so I think that's a very good use of that technology to stay close to the patient and close to what their uric acid is.
And
Mark?
I
Go ahead. Go ahead.
I also believe, I think that, the telemedicine is very good. And also you can do FaceTime, right? So there's different aspects of telemedicine, however you want to umbrella it, so to speak, but you can see a joint now through the Zoom meeting if they have the capabilities. Unfortunately, a lot of the populations they still have a house phone. They don't know how to use a cell phone and take a picture and send it to me, or they don't know how to have a Zoom or video or whatever. But telemedicine, I think, is really helped out a lot for just, all right, let me see what it looks like in the acute flare. If not, please take a picture. A lot of times they can't get into the doc, or they can't, it's after hours or whatever. So I think the camera and the telemedicine, or that phone, is really, really important, short term and long term. And again, I think it comes down to that re-education process where we're trying to dispel what's out there on the internet, or what the family has told them, or what their friends has told them, their golf buddies have told them. So we talk about pickleball and paddle sports, but golf is a big one too, where we see it at all levels, and they want to socialize around an activity. You won't see it in bridge or mahjong, but you're going to see it in other card games where they will go and socialize with that, and then that's where a lot of that dialogue takes place, and a lot of times it's misinformation. But again, going back to the original question, with my job is to keep them moving. So if I don't keep them moving, what's going to happen to their sugar, their cholesterol, their blood pressure, whether it's short term or long term? And that plays into my education, my knowledge to educate them, or my ability to educate them about it is a multi-system disease. This is not just a foot issue or knee issue or a wrist issue. This is deep. This goes deep. And I think that's where we really have to say that there's ramifications other than a painful big toe joint, arthritis of the midfoot because you have a kidney transplant. You really gotta like collaborate here and say this is a multi-system disease, just like diabetes is a multi-system disease, and then people are undereducated about this, and I would say the numbers are probably higher than we really know. That comes out in the statistics that's out there that you've originally disclosed in the beginning of this meeting.
Good. Yeah, and Ted had brought the nephrology part up of this, Mark. I think a lot of the concern dates back to the mid 80s when a kind of off the cuff, not really research supported equation for how bad your kidneys were functioning with how high your allopurinol dose can be. Is there any attempt to dissuade the population of nephrologists at large that this is antiquated thinking?
We do try. We do try. As you know, with all things that you're putting forth, it takes decades to get through to everyone, and that re-education has to continue to happen because as you were talking about, the pharmacist may be the one to tell them, or so it's not always the nephrology you have to get to, but there's so many points of failure in this. And if you have a reluctant patient and they hear one thing negative from any of their interacting physicians or with the pharmacist, or from a neighbor or a friend, they're more likely to stop it.
Yeah, Paul, one thing that I hear from primary care physicians when I go out and talk to their organizations is that they're busy. and you know, in a 15-minute visit with their patients, you know, they do have a lot of these other comorbid problems: the diabetes, the hypertension, the hyperlipidemia, kidney disease. You know, and by the time they get down to the hyperuricemia and the history of gout, there isn't much time left in that. Is that just a inherent problem, or is there a way around that that can get gout moved up to a little higher rung on the ladder, I guess?
Well, I think that if a primary care provider knows that, as Nick said, this is a systemic problem, that hyperuricemia has far-reaching issues. We already talked about cardiovascular disease. We know its association with renal disease. You've already talked about the fact that it can lead to chronic arthritic condition. When a primary care provider knows that this is far-reaching, it's a gout attack is just the tip of the iceberg. Maybe it'll elevate in their hierarchy of what to talk about with the patient, the fact that they need to deal with gout properly, to make sure that their uric acid is at target, to make sure that their comorbidities are dealt with, and also have a plan for the acute attack. You know, the beauty of primary care is we get to see our patients often. You know, usually it's a once-a-year complete physical and several times in between for gout patients because they have comorbidities like diabetes and obesity and hypertension and chronic kidney disease and arthritis, etc. So we're seeing them often. So fortunately, we have multiple touches where we can actually at some point devote a good bit of time for hyperuricemia and gout. It's just that, like I said, primary care providers need to know more about the fact that this is a far-reaching problem. It's not just a painful joint that occurs now and then they can treat with an NSAID.
Yeah, it's gout's a complex disease to treat, although a fair percentage of gout patients can be managed by an algorithm, I think, that's been shown in several studies of dedicated gout clinics that are run by nurses or nurse practitioners or PAs, and our case in Gainesville, that success can be very high. You know, I've mentioned the statistics before of only about 1 in 10 patients with gout actually getting on not just a proper dose of urate lowering therapy, but remaining on it long enough to have a substantial effect on the disease process. Our treatment should be lifelong. But Mike Doherty and the UK and several places here in the United States that have had nurse or PA run programs have been highly successful. I think in your gout clinic, Joan, you had a little stricter target that you shot for, and I think a lot of those patients were down close to 4, but a very high percentage of them were at that dose and remained in there. What do you think, Joan, of the idea of having these dedicated gout clinics that are run by extenders, and what do you think the magic of that is? Is it your willingness to shoot up on the allopurinol, or is it that you're educating them more frequently?
I think it's that chance to really break the out of sight, out of mind image that gout often has to the patient, like make the pain go away and then I don't have to deal with it anymore. You know, it's like I get my hooks in them, well, they're not going to get off the hook, you know, until they've reached their target. So with some people, you sort of have to, I find I really have to baby them along, and other people I have to be, like a strict schoolmarm, my way or the highway. So I think that's the nice thing about seeing people frequently and having a very non-judgmental approach and a compassionate approach and meeting them where they're at. People's health literacy is very, very different. Patient to patient, you have to open your ears differently, each time you see a patient. Some people, their health literacy is never going to change, and so they're very eager to have it change.
Yeah, there's a study out of South Korea where large group of rheumatologists, and sole in their practice, every patient with gout got a standardized education about the underlying disease process of gout, about the stages of gout and its progression, about the reason for anti-inflammatory drugs to treat the symptoms and urate lowering therapy to treat the actual cause of the problem. And they were started on urate lowering therapies. At the end of a year, 40% of them had stopped taking their urate lowering therapy, and by a year and a half, 60% had stopped taking it. And that's despite, again, this very organized educational process. I think the take-home message from that was that the education has to be ongoing, that you can't hit them at one time with some information about the disease. You have to kind of reinforce that each time, that patients have a hard time understanding that if your target is 6 and their uric acid levels down at 5.5, why are they still having gout flares? And then you have to go back and say, well, this is a disease of urate burden. It took you years to decades to accumulate this quantum of uric acid crystals around your soft tissues. It's going to take years, maybe 3, 4, even 5 years in some patients with a target uric acid of 6 achieved to deplete the body of that. And until all the crystals are gone, they're still at risk for this inflammatory process to be triggered. So I think that that's one of the lessons that we learned, that there is no single speech that you can give to a patient and then not worry about them for the rest of their life, which is the duration of urate lowering therapy. Well, let's talk a little bit just about collaboration with each other. Is it important that rheumatologists are better than that? Is it important that a collaboration be developed, Paul, between rheumatologists and primary care physicians about gout? Or is it certain parts of the gout population that you're going to take care of and certain parts of the gout population that they'll take care of? Or should primary care physicians be taking care of all parts of it with occasional collaboration with rheumatologists?
Well, as with all aspects of primary care, everybody has a comfort level, whether it's diabetes, hypertension, coronary disease, depression, anxiety, obesity. We have our comfort levels of how far we can go with each condition. There are some primary care providers, when they see a gout attack, they'll refer right away to a rheumatologist. They just don't want to handle any parts of it. There are others, though, that will take it all the way to the very end and will only refer to a rheumatologist when they get stuck. Either they can't get the uric acid down, or they can't get rid of a flare well enough, then they'll consult with a rheumatologist. There's a bit of a problem, I must say, around the country, if I'm not mistaken, correct me if I'm wrong, that it's difficult to get some patients to see a rheumatologist for a while. It may take 2, 3, or 4 months until they can see a rheumatologist. There aren't just that many to go around. But nonetheless, we should collaborate with our rheumatologist colleagues in several different instances, depending on your comfort level.
Yeah. Is there a problem with nephrologists and rheumatologists co-managing patients, Mark?
No, I think what I try to do is be very clear, educating the patient. And hopefully I'm not telling a rheumatologist that they can go up on the allopurinol. But in my note, I sort of make it clear that the dose of the allopurinol, you can increase that until you get to target. So everyone who's caring for the patient and the patient themselves are aware of what's going on.
Okay. I'm sure that could happen at some stage, that you would find a rheumatologist you have to talk into going higher. Ted, how do you develop collaborations on this regard? Are you offering them to oversee the escalation of allopurinol up to a dose, or do you ask them to let you just take it over?
Once they're referred to me, I work on the assumption that they want me to get that patient to goal, that they want me to drive that. And I pride myself on communication with referring doctors, and you really have to go to that extra effort to communicate. And I think I often hand back patients to primary care, get them help once we get them to goal, flare free, doing pretty well, I'll hand them back. And I send a note at that point, that sort of warm handoff back to primary care about sort of what my long-term vision of what that management looks like. Not overly detailed, but that this is like a lifelong therapy when we're talking about urate lowering therapy. I do tell the patient, and I hope providers aren't offended, but I say, if anyone wants to decrease or stop your allopurinol, that's a phone call to me. Because I do see there's a lot of interruptions in that therapy without that statement being made, and sometimes it's justified, but usually it's not. And so I really try to step in and have that set up in advance if there's a question about the therapy.
Yeah. And I think telling patients that generally allopurinol or febuxostat are lifelong therapies, and very rarely is there an indication for stopping them there. I think it was mentioned before that people stop it every time there's a flare. There's physicians that tell their patients stop the allopurinol anytime they go into the hospital. I think that needs to be short-circuited. Yeah, and Nick, you're seeing patients. Who do you refer to when you think that they have gout that needs therapy? Yeah.
So I think it's a couple of things. I'd like to go back a little bit and discuss that when you get it to that 6.0 number and they're still having pain, and it may take 1 to 3 years to normalize, so to speak. I think that's where imaging can come in and say they have destruction in a big toe joint or a midfoot or a knee from having elevated levels of uric acid. So I think that's the power of old-fashioned bone scan. Again, we have to be careful of the dye with the kidney, or an MRI, CT scan to just look at bone where we see that destruction, and just going back to a simple X-ray, and that just shows the patient visually that, listen, you have a chronic pain, but you also destroyed that joint, and you will have pain because that joint is not working as it used to work before. So I think that's where some of the imaging can come in, just to help solidify and re-educate them and say, hey, listen, you may need a different shoe or orthotic than they're custom made. And that's a whole other way of, again, my job is to keep them moving for many reasons. And I think what we're all discussing here, a common bond that we have is it's all about comprehensive care. We can collaborate, but again, it's comprehensive care. I think where everybody is from the foot up, so to speak, or from the kidney down or whatever, it's comprehensive care, having a team approach, and that patient has to be educated that this is not just one organ, one joint. This is a fully systemic issue that can really attack anything chronically or acutely, and we all have to participate in comprehensive care through EMR or a phone call or a picture or telemedicine or telehealth. And I think that's really what it comes down to, where I'm involved in that. And as Paul said, I see the patient every 6 to 9 weeks, okay, or up to 3 months. So I'm going to pick that up first in a lot of ways, because I see them so often. But also, if they can't walk because something's hurting with a knee, or they can't tie the shoe because of their wrist, or they can't push off and go down the stairs because their ankle, big toe joint, or midfoot is bothersome, I'm going to see that pretty often, where I need to pick up a phone or send a note and say, listen, we need to advance imaging, get BP blood work, and then send them off to a lot of times a primary care physician first, a family practice medicine individual. And then, if they already have a nephrologist or a rheumatologist, they can jump in as well. But again, they come to me first off because they can't get a shoe on. They can't ambulate like they want to.
Yeah, I think imaging's an important advancement. We talked about the genetics before as being an important new aspect of thinking about gout, but imaging, serial imaging is certainly hopeful now. But and somebody had mentioned early on in this conversation about how few times people are doing arthrocentesis and looking for crystals in synovial fluid, and that's been true for a very long time. I think it's getting more and more rare, and one of the reasons it's getting more rare is that an alternative to that is the use of just ultrasound. So no dye, no radiation exposure, but very telltale changes that occur in these joints. And I think that that's helpful in explaining to patients that there's still evidence of tophi around the joint, that there's crystal shedding. They can see that in the joints. There's also the DEX scans, the dual energy CT scans that can give you very detailed pictures of uric acid deposits. And I think that that's part of the educational approach always, is to show those kinds of scans and how diffuse this the urate deposition is around the body. How, if the onset of hyperuricemia in genetically predisposed males, if they start developing their adult elevated level of uric acid when they're 14 or 15, it might be 25 years later that they've really accumulated that level of urate burden, that they're starting to have symptoms, and it's going to take a while to reverse that process.
What I might add is that we haven't really touched on is the importance of nutrition consult and bringing that individual in as far as the comprehensive care. And again, that may play into the kidney aspect, the rheumatology aspect with inflammatory foods, or to the diabetic and looking at hidden sugars and carbohydrates in food, as well as your typical foods that may, aggravate, cause, or alter, the urate levels, the uric acid levels. So I think that's where we kind of fall behind on that. That again, that's another educational piece that may affect multiple systems. That nutrition specialist may help us out in multiple systems that we're all discussing today.
That's important. Let me just hear from everybody. Paul, what do you tell patients about diet? They come in and say, I want a gout diet. What is your approach to that?
It's interesting. One of the biggest misconceptions to a lot of people that have gout, when you tell them you have gout, the first thing they say is, well, I don't eat shrimp and I don't eat meat that much. For some reason, they have this idea that it's a food-related issue. And as you said very appropriately, Larry, this is a genetic condition. I mean, this is a hereditary problem in most cases. There are other causes as well, but in most cases, you see this genetic issue. So what I tell patients is that we have to lower the uric acid. Typically, it's going to be with medicine, but dietary changes will help. Very similar to, let's say, hypertension and salt and diabetes and carbohydrates. Medication plus lifestyle change is the way to go, not just dietary changes. So as far as the dietary changes go, I do give them advice on it. We have a dietitian in our group, and I do refer my patients to her to go over things. So it's a combination of medication and lifestyle change, and that predominantly that lifestyle change is dietary changes. But let's not forget about weight loss, because very important and helpful in lowering uric acid.
Agree with that. Mark, do you tell your patients anything specifically about diet?
Well, with regards to diet, what I hear from my patients is when they measure it, they have a uric acid of 13, they say, oh, my diet's been really bad. And I have to convince them there's no way they're going to get it down to where they need just by diet alone, please start this medication. I always sort of recommend to people that, the DASH diet is one that I recommend. Also, vegetarian diet is better than, if you're going to have protein, vegetarian protein is better than fish protein. Fish protein is better than chicken protein. Chicken protein is better than steak. But it's the most important thing for patients is really to take the medication, take their treatment, and don't think that diet alone, although we want to encourage a good diet for lots of other reasons, diet alone is not going to handle their gout.
Joan, what do you tell patients?
Well, I think you really have to sort of drill in on what their beliefs are that's causing it. I mean, if someone is utterly fixated that they could fix it with cherry juice and not eating a steak, you've got to. So I just give them a little time to fail, because if they're really fixated, I don't want to be in locked horns with them. And as long as I can get back with them and show how little it changed, and certainly if they have a flare, then that's the teacher. But I think the biggest thing really is alcohol consumption. I mean, I think that there are people underestimate and underreport what they drink, particularly beer. And, I think that for a lot of people, giving up beer is nearly impossible, but cutting back is not impossible. So I do spend a fair amount of time trying to drill down on exactly how much do they drink, and how can that be modified.
How about you, Ted? Do you have any?
Well, I'd make the first comment that it's a rare patient who doesn't want to talk about diet. So I think as a provider, you better be comfortable talking about it, because you're going to have a really long morning in the clinic if you're not. So it's a really common conversation. I think Nick said it, it's part of a holistic management, really. And these patients have, as we have said over and over, often have obesity and chronic kidney disease and diabetes. And so a healthy diet, which I am certainly no dietitian, but a healthy diet is an important aspect of holistic care. I think one of the things I try to do in clinic is disconnect the diet discussion from serum urate control to the degree I can.
Yeah.
And I really talk to them about noting and maybe even keeping a diary on diet as it relates to flares, because there's a lot of data that diet probably plays a bigger role on the flare side, that it is a trigger in some people. It varies what that is for flares. And alcohol is a famous one, I think, for doing that. But also high fructose corn syrup does that as well. And there's others. And so I try to talk to them about that. And I think a lot of patients come in very open-minded in terms of diet. Some do come in with kind of preconceived notions, as Joan had mentioned. But I think many people have just heard that diet's important. They want to learn from you. And so that's, briefly kind of approach I take.
So emphasizing that the food and alcohol isn't the cause of their gout, but it might be the cause of their flares. And I think by the time most patients get in to see me, they've already identified if they have a flare food or a flare drink, what it is, and maybe want to avoid that in the future. I think we're closing in on the end of this discussion. I want to thank everybody for their input on this, with a wide spectrum of medical specialties and caregivers here. And I think that we can all look at the facts as they exist in 2023 and say, there is an approach that we should be taking, and we should dispel a lot of the old myths from before. I think that, the science marches on, and recognizing the genetic underpinning of this disease, the close association with other metabolic diseases, maybe even the precipitation of significant cardiac disease with uncontrolled gout and its flares is something that we would all agree makes gout a significant disease, something with consequences, and it should be approached very much the way other chronic conditions like diabetes and hypertension are. I want to thank you all for joining us. You've been terrific. I hope we help some patients out there.